Assalamu alaikum. And a very warm welcome from the Department of Dermatology, PNS SHIFA Hospital, Karachi. I'm Professor Athiya Rahman, the departmental head. This is the 24th Dermatology CLINICOPATHOLOGICAL Conference and the first of the year 2026. We wish you all a very exciting, productive, and rewarding year ahead. Today, we have assembled a variety of cases, and we hope this academic activity will be intellectually stimulating for all of us. The cases highlight how close collaboration between different specialties bring out the best possible outcome for the patients. PNS SHIFA is distinguished as the sole institution of Sindh offering fellowship in pediatric dermatology. So our first case will be presented by Dr. Madiha Hanif, who is a consultant dermatologist and pursuing fellowship in pediatric dermatology.
Assalamu alaikum everyone. I welcome all of you to this 24th Clinico-Pathological Conference. I am Dr. Madiha Hanif, consultant dermatologist and registrar pediatric dermatology at PNS SHIFA, Karachi. The topic of my case is When the Skin Speaks, a clue to syndromic diagnosis. It is presented, this case is supervised by my mentor, Professor Athiya Rahman, who is the head of the Department of Dermatology, Bahria University of Health Science and Karachi and PNS SHIFA. Let's begin with our case. Case is about a male baby of 2.3 kg weight who was born on 15th May 2025 to a 30-year-old primary gravida mother who is a resident of Hyderabad. Baby was admitted to NICU or neonatal intensive care unit on 15th May 2025 due to respiratory distress, tachypnea of about 68 breaths per minute. The mother initially received antenatal care at a private clinic where an early ultrasound at 8 weeks confirmed a single viable intrauterine pregnancy. A detailed anomaly scan was not performed, likely due to lack of appropriate referral or counseling at that stage. There was no history of gestational diabetes or pregnancy-induced hypertension, and the mother denied any history of radiation exposure, drugs, except multivitamins and calcium supplements prescribed by a gynecologist. Baby was delivered via lower segment C-section due to severe oligohydramnios by a consultant gynecologist at PNS SHIFA, Karachi. Baby cried immediately after birth. APGAR score at 1 and 5 minutes was 7 and 9 respectively. Delivery was attended by PEDS duty medical officer. The baby had tachypnea, respiratory rate of about 68 breaths per minute. The baby transferred to neonatal intensive care unit on low flow oxygen via face mask accompanied with PEDS duty medical officer. Parents are married for 3 years and are non-consanguineous. Maternal and paternal history was insignificant. So moving on to the general physical examination. Baby's vitals were, the baby's blood pressure was about 82 by 44 millimeter of mercury. Pulse it was about 138 beats per minute. He was afebrile with the respiratory rate of about 68 breaths per minute, and capillary refill time was about more than 3 seconds, and oxygen saturation was 96% on room air. Baby was pink in color, no pallor, jaundice or cyanosis was observed. According to WHO growth charts, the baby's weight, length and head circumference falls below the 3rd percentile for the gestational age, suggestive of significant growth restriction. On craniofacial examination, the baby demonstrates dolichocephalic head shape, which is characterized by an elongated anterior-posterior diameter with narrow biparietal width. Microophthalmia, hypertelorism, flat nasal bridge, bilateral cleft lip and palate, low set malformed ears was also observed. On cutaneous examination of the scalp, there was 2 distinct lesions of 2 by 3 centimeter, one characterized by absent skin with a translucent membrane and prominent underlying veins, and the other presenting as a localized area of alopecia without overlying skin defect. On further examination of the upper extremities, there was bilateral post-axial polydactyly, which refers to the presence of an extra digit on the ulnar side of the hand. And on examination of the lower extremities, there was rocker bottom feet, which is a congenital foot abnormality in which the sole of the foot is convex, giving it a shape similar to a rocker of a rocking chair. On examination of the lumbosacral midline defect, there was a localized patch of dense coarse terminal hair on the lumbosacral midline consistent with the Fontaine nevus, and on examination of the male genitalia, there was underdeveloped male genitalia. So, according to the clinical history and clinical feature, according to a history and clinical features, following differential diagnoses were considered: Patau syndrome, Adams-Oliver syndrome, Johansson-Bilizard syndrome. I would like to discuss these key features of these syndromes later on. Moving on to the systemic examination, on cardiovascular examination, S1 and S2 was audible with harsh systolic murmur all over the precordium. On respiratory examination, there was tachypnea. Rest of the respiratory, CNS and abdominal examination was unremarkable. So now to summarize my case, a male neonate weighing 2.3 kg, born to a primary gravida mother via lower segment cesarean section at 38 weeks of gestation, which was performed due to severe oligohydramnios. Admission required to neonatal intensive care unit immediately after birth because of tachypnea and respiratory distress. Detailed clinical examination showed multiple dysmorphic features and craniofacial anomalies. Cutaneous examination revealed two well-demarcated lesions of absence of the skin over the scalp. Given the presence of low birth weight, oligohydramnios, craniofacial defects, dysmorphism and a scalp defect, a syndromic association was strongly suspected. This slide summarized the important features of the differential diagnosis which we were considered during evaluation. In Patau syndrome is basically a lethal chromosomal disorder. It is a trisomy of chromosome 13, and it is characterized by multiple craniofacial anomalies including microophthalmia, post-axial polydactyly, cleft lip palate, low set ears, and congenital heart defects, and it carries a poor prognosis with a high neonatal mortality rate. Whereas Adams-Oliver syndrome is an autosomal dominant and autosomal recessive disorder, and it is also characterized by scalp defects along with terminal limb defects and vascular malformations, and its prognosis is variable. Whereas Johansson-Bilizard syndrome is an autosomal disorder, and it is characterized by nasal alar hypoplasia with pancreatic exocrine insufficiency and sensorineural hearing loss, and it carries also a poor prognosis. So our case has a similar clinical features as in Patau syndrome. So moving on to the investigations. The complete blood picture shows high TLC count. Rest of the parameters were within normal limits. Renal function test demonstrates elevated urea, creatinine and sodium, while potassium remained normal. Liver function test and coagulation profile was within normal limits. In view of the lumbosacral midline defect with an overlying tuft of hair, appropriate radiological investigation were carried out to rule out any underlying pathology. In this regard, ultrasound of the brain and MRI of the brain was performed, and which was essentially unremarkable. As the baby had a harsh murmur on cardiac examination, echocardiography was performed by a pediatric cardiologist at PNS SHIFA, Karachi. The study revealed ventricular septal defect, atrial septal defect, and patent ductus arteriosus. And ultrasound kidney urinary bladder was done, which showed bilateral mild hydronephrosis. With the involvement of the cutaneous involvement and multi-system involvement, genetic evaluation was pursued, in which the karyotyping was done, which showed trisomy 13. This picture shows the chromosomal analysis of the baby, in which all the metaphyses showed an extra chromosome number 13. So after a detailed workup, history workup and systemic examination, the final diagnosis of aplasia cutis congenita with Patau syndrome was established. The baby initially received a multidisciplinary management with a neonatologist, pediatric cardiologist and dermatologist. As there was no any need of surgical intervention, supportive neonatal intensive care unit care was advised, and the parents were counseled about the regarding grave prognosis of the condition, and genetic counseling was advised for future pregnancies. The baby initially managed on low flow oxygen via face mask, and later on the high flow oxygen at 5 liters per minute was started as the respiratory distress ensues. Baby was tolerating orogastric feed with express breast milk, and IV broad spectrum antibiotics ampicillin, amikacin, tazobactam and piperacillin was administered. Local wound care was provided with a moist gauze dressing along with topical antibiotic ointments. Baby was discharged on 12th day of life. Mother was counseled regarding the orogastric feeding at home, and family was counseled about the grave prognosis. Unfortunately, baby died on 40th day of life. Now, I will briefly discuss the topic in relation to our case. Aplasia cutis congenita is a rare birth defect with an incidence estimated at 1:10,000 births and a prevalence of 1 case per 5,000. Described as the focal absence of skin noticed at birth, it was reported for the first time by Cordon with the involvement of limbs in 1767. In 1826, Campbell first described the aplasia cutis congenita of the scalp, which is reported as the most common site for this defect in nearly 90% of the cases. The exact mechanism of this defect is not completely understood, and etiological classification based on the location of skin defect and the presence or absence of other malformation proposed by Fredden divides this pathology into 9 groups. This is the Fredden classification for aplasia cutis congenita. Now I will briefly discuss the literature review available for the associated with the aplasia cutis congenita with Patau syndrome. This case report has been taken from Acta Scientific Pediatrics, published in August 2021. And in this article, it is a case of a male newborn issued from a non-consanguineous marriage and non-monitored pregnancy without any drug intake during pregnancy. Vaginal delivery with a birth weight of 2,500 gram. In this case report, patient present with similar craniofacial anomalies and dysmorphic features, along with hypotonia, polydactyly and agenesis of the left kidney. And his karyotype revealed the presence of trisomy 13. The aim of this article is to study the clinical, therapeutic and progressive aspect of this rare congenital disorder. This is another case report taken from Frontiers in Pediatrics published in March 2023, and this case report also has similar features as in our case. This is another case report taken from Turkish Journal of Pediatrics published in 2009, and in this case report 3 cases of aplasia cutis congenita of the scalp with different etiologies were observed, in which the pathology was pathology is congenital rubella syndrome, trisomy 13 and fetal valproate syndrome. The aim of the present report is to discuss the awareness of these skin defects and emphasize the importance of underlying etiologies. So to conclude my case, aplasia cutis congenita is a physical finding. It is in general an isolated skin defect, but it can be a part of polymalformation syndrome and may have many etiologies. Despite its exceptional character, this neonatal defect must be known and carefully taken care of, as it can be life-threatening to the newborn. Given the grave prognosis of Patau syndrome, management is largely supportive and requires a multidisciplinary approach. Early diagnosis during antenatal period allows for realistic prognostic counseling, informed parental decision-making, and compassionate planning of care, emphasizing quality of life and ethical consideration. Thank you for your active and attentive listening. Now I would like to invite my Vardi supervisor, Professor Atiya Rahman.
Thank you, Dr. Madiha. It was a very well presented case. And our aim is to highlight that cutis aplasia is associated with this rare syndrome as well. And it is a severe genetic disorder associated with a high mortality. Most of the new infants, they do not survive the first year of life. And the other aspect was the psychological distress and anguish caused to the parents due to lack of antenatal care. The mother first came to PNS SHIFA when she was 38 weeks pregnant, and at that time, due to severe oligohydramnios and fetal abnormalities, skull defects, as well as heart defects, they were detected, and the parents were then counseled and karyotyping done, and they were advised that in their subsequent pregnancy, because the mother is primigravida, that she needs to have regular antenatal care. So if the audience have any questions, you're more than welcome.
Is this the first case in our country?
To the best of our knowledge, we did not find this in our local literature, and that is why we presented it here, and we plan to publish it. The initial research did not reveal it. If there isn't any question, then we will proceed with our second case by Dr. Izza Adnan.
Bismillahirrahmanirrahim. Assalamu alaikum everyone. I am Dr. Izza Adnan, resident dermatology at PNS SHIFA Hospital, Karachi. The topic of my presentation is generalized pustulosis, a unique dilemma, which I have prepared under the able guidance of my supervisor, Professor Atiya Rahman, who is also the head of dermatology department at PNS SHIFA. This will be the sequence of my presentation. So I present to you a case of a 36-year-old male from Haripur, driver by profession, who presented to us in dermatology OPD on 1st July 2025 with the complaints of red raised lesions with pustules on his body for 20 days. Our patient was completely well 20 days back when he developed red raised lesions filled with pus, which initially appeared on his abdomen and then gradually extended to his neck, thighs, and arms. There was no association with pain, fever, malaise, itching, or joint pain. Initially, our patient did not give us any drug history that he associated with his cutaneous eruption. However, upon persistent inquiry, he recalled that he took a single tablet of Panadol 2 to 3 days before his eruption. His systemic review was unremarkable, and he had no comorbids, and there was no previous history of similar cutaneous lesions, nor did he give us any such family history. On physical examination, he was a young male of average build, well-oriented and cooperative. He was vitally stable. His general physical examination was unremarkable. And on cutaneous examination, there were multiple scattered erythematous plaques studded with sheets of pustules involving the left side of his neck, abdomen, back, and bilateral thighs. On his knee, the pustules had coalesced to form a lake of pus. His scalp, hair, nails, and mucosa were normal. His systemic examination was unremarkable. And on the basis of history and examination, our differential diagnosis included acute generalized exanthematous pustulosis, which is also known as AGIP, pustular psoriasis, subcorneal pustular dermatosis, and IgA variant of pemphigus. We admitted our patient and started our management accordingly. Investigations included complete blood count, which showed borderline leukocytosis with raised neutrophils on differential leukocyte count. His CRP was raised, Liver function test and renal function tests were unremarkable, and pus CS did not reveal any growth. We performed a skin biopsy from his abdomen, and this was the histopathology. The epidermis showed focal parakeratosis, subcorneal pustules containing neutrophils, eosinophils, lymphocytes, and necrotic keratinocytes. Along with that, there was exocytosis, spongiosis, focal vacuolar degeneration of basal layer, and the dermis showed marked edema and mixed infiltration of neutrophils, lymphocytes, and histiocytes. These findings were suggestive of AGIP. So keeping in mind the short clinical history, drug history, and our histopathology report, we considered AGIP as our top differential, and we started our management accordingly. We advised our patient to avoid paracetamol, and we started oral prednisolone in a dose of 20 mg per day. Initially, our patient's clinical condition improved. However, the response was suboptimal. After a few days, he developed a new crop of pustules on his body. Now, AGIP is a self-resolving condition and usually resolves on its own once the drug is stopped, or it requires a short-term course of corticosteroids. However, in our case, this was not the case. We asked our patient if he had taken paracetamol or any other medication other than what we had prescribed him, but he denied any such intake. We increased the dose of prednisolone to 30 mg per day, but still there was minimal improvement. So then we questioned ourselves that is this steroid-resistant AGIP, or should we consider some other diagnosis? We did some literature review, and we found that although AGIP and pustular psoriasis have overlapping clinical and histopathological features, but there are a few distinguishing features to help differentiate the two entities. And since our patient's histopathology lacked the typical psoriasiform features like elongation of rete ridges, suprapapillary thinning, or absence of granular layer, and had findings which were very suggestive of AGIP, so we remained consistent with our diagnosis. Then, upon further literature review, an article published in the Journal of American Academy of Dermatology supported the use of cyclosporine as an effective treatment option in treating steroid-resistant cases of AGIP. So, we added cyclosporine in a dose of 200 mg per day in our treatment. And to our delight, our patient started improving. This is a picture taken 10 days after initiating cyclosporine, and you can see that the pustules have resolved. However, there is still minimal erythema and scaling. After a few days, we started tapering off prednisolone and cyclosporine, but unfortunately, as we did so, our patient's disease aggravated with development of new crops of pustules. This new development forced us to reconsider our diagnosis, and so we decided to do a rebiopsy along with DIF. The DIF was negative, which ruled out IgA pemphigus. And the histopathology was similar to our previous report, favoring AGIP. So we continued our management with the same dose of prednisolone and cyclosporine, and then very gradually started tapering off the drugs. Fortunately, our patient started improving, and this picture here shows how his lesions cleared after 4 weeks of treatment. We discharged our patient on 14th August 2025 with this treatment, including low-dose oral prednisolone, 5 mg on alternate days, cyclosporine 100 mg per day. We advised him to avoid paracetamol and asked him to follow up after 2 weeks. After that, our patient went on to leave to his hometown, where he experienced some abdominal symptoms. He visited a nearby tertiary care hospital in Islamabad, where he was admitted and treated with antibiotics and topical ointments. Cyclosporine was discontinued. His symptoms improved and he was discharged. However, after a few days, he experienced a fresh crop of pustules all over his body. And this time, he had severe joint pain and swelling involving bilateral knees, ankles, and spine. There was no history of paracetamol or any other inciting drug. He visited another tertiary care hospital in Rawalpindi, where he was admitted and jointly managed by dermatology and rheumatology teams. He was thoroughly investigated. His ANA was negative, RA factor was also negative, skin biopsy for histopathology was done, and bone scan was also done. The histopathology findings were similar to the ones reported previously in our hospital. But in addition to that, there was focally attenuated granular layer in the epidermis. Thus, the report had overlapping features of pustular psoriasis and subcorneal pustular dermatosis. The bone scan showed intense radiotracer uptake in spine, sacroiliac joints, hip joints, and mildly increased uptake in the peripheral joints, suggestive of spondyloarthritis. He was managed with prednisolone in a dose of 25 mg per day, acitretin 25 mg twice daily, and methotrexate 7.5 mg weekly, after which he improved and he was discharged. After this, our patient returned to Karachi and presented back to us on 27 November 2025 with diffuse erythema, mild scaling, and pustules over his trunk, neck, upper back, and bilateral limbs. Along with that, there was also fatigability, malaise, and lower backache. Keeping in mind the development of his joint symptoms, rheumatology department was taken on board, and we revised our differentials, keeping pustular psoriasis on top and adding Sappho syndrome to our list of differentials. And since there was no drug history, so we excluded Egypt from our differentials. Serum protein electrophoresis was done to see if there is any underlying monoclonal gammopathy which could be associated with subcorneal pustular dermatosis, but no monoclonal band was observed. Keeping in view his backache, MRI of sacroiliac joints was performed, which showed fatty marrow changes around both sacroiliac joints. The case was discussed in our weekly dermatopathology meetings with all 3 histopathology reports, and then we did some literature review. In an article published by JAMA Dermatology, it was seen that generalized pustular psoriasis can present histologically as subcorneal pustular dermatosis and later on acquire typical psoriasiform changes on subsequent serial skin biopsies. Another case report from USA, which was published in Pediatric Dermatology Journal, shows how a 10-year-old boy initially managed as a case of subcorneal pustular dermatosis was later diagnosed as annular pustular psoriasis. With success, this study suggests that the 2 disorders represent a spectrum of the same disease. Another case report from Malaysia highlights how subcorneal pustular dermatosis is a great mimicker of pustular psoriasis. Then we also did some literature review on Sappho syndrome, which is an autoinflammatory disease classically entailing synovitis, acne, pustulosis, hyperostosis, and osteitis. According to a review article published by Rheumatology International, the osteoarticular involvement is the key feature in SAPHO syndrome, and dermatological involvement has been seen in 60 to 90% of cases, with psoriasis and acne as the most common skin conditions. Classically, it is the palmoplantar pustulosis that is seen in SAPHO syndrome. However, the clinical presentation can be heterogeneous. In an article in another study from Tunisia, which was published in the Egyptian Rheumatologist, skin involvement was seen in 1/3 of patients and axial disease in 93% of cases of SAPHO syndrome. So, keeping in mind the evolution of our patients' clinical symptoms, diagnostic workup, and literature review, we narrowed down our differentials to pustular psoriasis as our clinical diagnosis. And although our patient did not have acne, but because his bone scan showed features of hyperostosis and MRI showed features of osteitis, both involving his axial joints, so the possibility of SAPHO syndrome cannot be ruled out. As for subcorneal pustular dermatosis, in our patient, flexures were spared and there was no monoclonal gammopathy associated. However, since there is strong clinical and histological overlap between subcorneal pustular dermatosis and pustular psoriasis, so it still remains in our list of differentials. Currently, our patient is in remission with this treatment, including low-dose prednisolone 5 mg on alternate day, acitretin 25 mg twice daily, and methotrexate 7.5 mg weekly. These are his current clinical pictures, and you can see that there is complete resolution of his cutaneous lesions. Our plan for this patient is that we will keep monitoring him with regular follow-up visits, see how his disease evolves in the future, and serial skin biopsies in case he experiences a flare again. So, dear colleagues, my take-home message for you all is that sometimes in life we face situations which leave us wondering for long. Similarly, in our clinical practice, sometimes we encounter patients whose exact diagnosis cannot be established. And such gray cases require holistic approach, thorough literature review, multidisciplinary management, along with meticulous long-term follow-up to evaluate disease evolution. These are my references. I thank you all. Now, I would like to invite my supervisor, Professor Athiya Rehman, for her comments.
Thank you, Dr. Isa, and for a wonderful, excellent presentation. And it's a true gray case where we have a working diagnosis but no definitive diagnosis. And as highlighted by Dr. Isa, years or probably even decades later, we might have the definitive diagnosis. So this case was very interesting, and we thought to present it in the CPC because it reflects an approach that is methodical, reflective, and balanced, and integrating clinical judgment with the available evidence. It made us realize that at times pustular psoriasis diagnosis is made without all the hallmarks of psoriasis, and then there is an overlap between subcorneal pustular dermatosis and pustular psoriasis. Patients being treated as subcorneal pustular dermatosis, decades later they turn out to be pustular psoriasis. And another interesting thing was about the SAPHO syndrome. We classically associate it with acne conglobata, being a conglomerate of synovitis, acne, hyperostitis, osteitis. So, but this made us realize the literature review that in 10 to 40% of the cases, the dermatological manifestations can be absent, and it is is the musculoskeletal system involvement, which is more important in the diagnosis of SAPHO syndrome. And all patients may not have all the classical features of a disease. So if anybody would like to have any comment or questions, they are welcome. Gigi, we can hear you. Can you? There's a question. Can you speak a bit louder, please?
Your next presentation is this आखिर में आप लोगों ने सैफो सिंड्रोम या फिर इसमें आपका क्या पस्टुलर सोराइसिस अच्छा अब मेरा एक क्वेश्चन है कि आप इतना ज़्यादा एग्रेसिवली इसको ट्रीट कर रहे हैं with the steroids plus methotrexate and retinoids. So what could be the reason behind it?
Yeah, thank you very much for your comments and question, and absolutely justified. It was a collaborative approach. The patient was, actually, he was discharged from our hospital. He went to a tertiary care hospital in Islamabad and then at Rawalpindi. And at Rawalpindi, he was totally unable to walk, and he was jointly seen by the rheumatologist and dermatologist, and they put him on delta-cortil. Their working diagnosis was pustular psoriasis. But then the rheumatologist, they are quite fond of having this anti-inflammatory drug, steroids. So now that he is here, we have counseled him and we are slowly tapering delta-cortil, and that is why currently it is 5 mg on alternate days. And we have told him specifically that if he gets unwell, we would really appreciate if he comes back to our hospital, and our plan is to totally remove delta-cortil from his regime. Even with retinoids, he was having flares, and especially for the joints, the axial involvement and the knee and the inability to walk, he was put on methotrexate, and he responded very well to methotrexate as far as the joint symptoms are concerned. Thank you very much. Thank you, Deep. It is very heartening to have comments from you. And now I would invite Dr. Zareen for the third case.
Bismillahirrahmanirrahim. Respected seniors and my dear fellow colleagues, Assalamu alaikum. I'm Dr. Zareen, resident dermatology, PNS SHIFA Hospital, Karachi. Today's presentation is about surgical management of basal cell carcinoma, a collaborative approach to margin clearance and functional reconstruction. This presentation has been supervised by Assistant Professor Dr. Muhammad Mudassir. Basal cell carcinoma is the most common form of skin malignancy. It is slow-growing and rarely metastasizes. Surgical excision remains the gold standard for most of the cases, aimed at complete tumor removal with histopathological margin clearance while preserving function and aesthetics. So we divide it into low-risk and high-risk BCC based on its location, its size, border, Either it is primary or recurrent, immune status of the patient, sites of prior radiotherapy, pathological subtype, and perineural invasion. Moving on to discussion, dermatosurgery for BCC. Most micrographic surgery is the gold standard with the highest cure rates, ideal for facial BCC, recurrent tumors, and tumors with ill-defined margins. The principles of dermatosurgery is complete tumor removal, histopathological margin clearance, and functional as well as aesthetic preservation. Collaborative approach. While most micrographic surgery is currently unavailable in Pakistan, so frozen sections are being utilized as an effective alternative for real-time margin assessment. Close coordination with histopathology team for intraoperative frozen section ensures real-time margin clearance. We also use this approach for some of the cases that we treated. Reconstructive options. Following confirmed clearance, defects are closed using various techniques. Primary closure for simple, smaller defects. Local flaps essential for closing defects while preserving functions and aesthetics. Skin grafts are used when local tissue laxity is insufficient for the flaps. In this section, I'll be presenting various flap techniques performed by our team, and all the images shown are from the real clinical cases. Local flaps are essential for closing skin defects after BCC excision. The following techniques were used based on primary motion of the tissue. Simple primary closure. Standard linear advancement of wound edges for smaller defects. Advancement flaps, including V2Y plasty, in which a triangular flap is advanced as an island connected by a subcutaneous pedicle to form a V2Y closure. This was utilized to preserve aesthetics in areas with limited tissue laxity. Rotation flaps, including standard rotation flap, in which tissue pivots around a fixed point in a curvy linear arc to fill the defect. Dorsal nasal rotation flap, a specialized rotation technique used specifically for complex reconstructions of the nose. Batman flap, a double rotation flap using two opposing curvy linear arms to close a circular defect, distributing the tension across two donor sites. Transposition flaps, including rhombic flap, a flap designed as a rhombus that is rotated over adjacent tissue to close a rhombic defect. It is highly effective for redistributing tension in facial defects. Bilobe flap, a specialized transposition flap typically used to move skin from an area of greater laxity into a defect. I will now present a case series of patients who were treated using these techniques. This first case involves a 65-year-old male with a hyperpigmented plaque on the left side of the forehead for 7 months. Based on clinical and dermatoscopic features, a provisional diagnosis of BCC was made and an elliptical excision of the lesion was done. This picture was taken on 10th post-procedure day. Here we have a 55-year-old female with provisional diagnosis of BCC who underwent an excision with V2Y plasty. These sequential images show the immediate and 10th post-operative day. The next patient was a 62-year-old male with a provisional diagnosis of BCC whose excision was done with rhombic flap. This picture was taken 1 year after the procedure and the final outcome was aesthetically very satisfactory. Case 4 was a 64-year-old female presented with a hyperpigmented plaque on the nose for 8 months with provisional diagnosis of BCC, was managed with excision and simple closure. Photographs were obtained on operative day, at 10th day post-procedure, at 3 months. Healing was complete with good aesthetic outcome. next patient, case 5, was a 57-year-old male with provisional diagnosis of BCC whose lesion was excised, followed by a rotation flap. The following slides demonstrate serial follow-up from operative day to 10th day to 3 months with good tissue approximation, wound healing, and very good aesthetic outcome. This is another example of excision with rotation flap of a BCC. This image showing immediate result, 10th day follow-up on 10th day, and 1 month outcome with optimal tissue approximation. Then we have a 66-year-old female with a hyperpigmented plaque on the nose for 8 months, having provisional diagnosis of BCC, was successfully managed with dorsal nasal rotation flap. Operative day photographs, 10th post-procedure day, and at 3 months. On follow-up, the flap showed excellent integration with well-maintained contour and aesthetics. Case 8 was a 59-year-old male with provisional diagnosis of nodular BCC who underwent excision with rhombic flap. Here you can see flap on the day of surgery, its condition on 10th day, and the results after 1 month. Now we have a patient, a 56-year-old female with a violaceous hyperpigmented nodular lesion on the lateral side of the nose extending to the medial canthus, compromising her vision for the last 6 months. The clinical and dermatoscopic findings were suggestive of BCC, so we plan to excise the lesion with a bilobed flap. The immediate surgical results can be seen in this picture. The next photographs were taken on the 10th day of follow-up visit. The final image shows 3 months follow-up result. Healing was complete with excellent cosmetic and functional outcomes. This is a provisional case of BCC. This is a provisional case of BCC based on clinical and dermatoscopic findings, having a violaceous plaque with mild central atrophy for 7 months. Following the excision, reconstruction was carried out by using a Batman flap. The picture was taken on operative day, and this picture was taken after 10 days. This is the result after 3 months. So now we will talk about complications and their management. Common complications include flap necrosis, infection, hematoma, dog ear formation, pin cushioning, poor cosmetic outcome. Their management. For necrosis, debride the non-viable tissue, consider secondary closure or graft. For infection, administer antibiotics, ensure drainage if needed. For dog ear or pin cushioning, surgical revision or monitor for resolution. For poor cosmesis, revise the scar with Z-plasty or laser therapy. So my take-home message is that malignant cutaneous lesion requires prompt evaluation and management. Aesthetic defect correction lies well within the domain of dermatosurgery. Dermatologists can safely perform these procedures, and with histopathology collaboration and the use of frozen sections, optimal outcomes are achievable without routine referrals or most micrographic surgery. I thank you all for patient listening, and now I would like to call my supervisor, Dr. Mohammad Mudassir, for his concluding remarks.
Excellent presentation that clearly demonstrates the principles of oncological dermatosurgery. The case series highlights a core challenge balancing complete removal and optimal functional and aesthetic reconstruction. Each flap choice, from simple closure to complex rhombic design, was a tailored solution to the unique anatomy of the defect. But remember, the art lies not just in executing the technique, but in the pre-op planning, anticipating tension, preserving blood supply, and managing the secondary defect. This shows thoughtful and skilled surgical management. ये सारी मेहनत जो हम लोग करते हैं इन सब में के पीछे बड़ा टेंशन वाला काम होता है. कभी चैलेंज हमें मिलता है कि जो हमने ग्राफ्ट लगाया है, जो फ्लैप लगाया है, वो ब्लड सप्लाई ले पाएगा या नहीं. काफ़ी पीछे केसेस दिखे हमें, पेलर टिश्यू आ जाता है या इस्कीमिया के चांसेस आ जाते हैं, तो उसमें क्लोज कोलैबोरेशन विद द पेशेंट हमें चाहिए कि जितना हमने पेशेंट को कॉन्फिडेंस में लेना वो आपके पास फॉलोअप में आएगा. अगर पेशेंट को कॉन्फिडेंस अब नहीं है, पेशेंट चला जाएगा और वो फिर किसी और क्लिनिक में जाएगा नेक्रोसिस के साथ, ग्राफ्ट फेलियर के साथ, और वो फिर जो है ना बदनामी का बायस बन जाता है. तो कॉम्प्लिकेशन प्रोसीजर, हर प्रोसीजर के साथ कॉम्प्लिकेशन रिलेटेड. तो अगर कोई भी कॉम्प्लिकेशन आ जाए, पेशेंट के साथ इन कॉन्टैक्ट रहें, खुद फ़ोन कर लें, उनसे पूछ लें ठीक जा रहा है, कोई मसला तो नहीं. दूसरे दिन, तीसरे दिन ज़रूर फॉलो अप पे बुलाएं. जो है ना ये हमारे लिए भी फ़ायदा हो जाता है, पेशेंट के भी फ़ायदा हो जाता है. Any question from the audience or from the listeners? So I would like to invite Dr. Sidra, our last presenter.
Assalamualaikum everyone. I am Dr. Sidra Anwar, resident dermatology at PNS SHIFA Hospital, Karachi. The title of my presentation is Beyond Hematologic Control: Skin as a Silent Messenger, prepared under the kind supervision of Dr. Madhiya Hanif, consultant dermatologist at PNS SHIFA Hospital. This will be the sequence of my presentation, starting from case presentation. A 66 years old married female, housewife by occupation, resident of Karachi. She was known case of hypertension and multiple myeloma. Presented to dermatology OPD on 17 January 2025 with the chief complaints of multiple red to purplish skin lesions predominantly involving face, neck, and trunk for 2 months. Similar lesions were present on scalp and oral mucosa. She was known case of multiple myeloma, diagnosed in July 2023. She was on chemotherapy for 1 year. She noticed the cutaneous lesions in November 2024, associated with mild itching. Lesions have been rapidly increasing in size and number despite proper adherence to chemotherapy regime. There were no aggravating or relieving factors. Her past medical history was significant for hypertension for 5 years, for which she was taking antihypertensive tablet amlodipine 10 mg once daily. On systemic review, she had history of muscle aches, joint pain, and decreased appetite. Rest of the systemic review was insignificant. On physical examination, a middle-aged female of average height and build, cooperative and well-oriented in time, place, and person with no signs of obvious distress. She was vitally stable on presentation. On general physical examination, she had pallor, clubbing, and pedal edema. Rest of the physical examination was insignificant. On cutaneous examination, there were multiple erythematous to oliceous nodules involving face, neck, and trunk, largest one approximately 1 by 2 cm in diameter, involving left lower face. Lesions are firm, non-compressible, and non-tender. There were no associated lymphadenopathy and any other skin lesions. Her systemic examination was unremarkable. Moving on to case summary, a 66-year-old female, known case of multiple myeloma and hypertension with a history of multiple erythematous to violaceous nodules on whole body, predominantly involving face, neck, upper back, and chest, also involving scalp and oral mucosa. The lesions were associated with mild itching and burning sensation in hands and feet. They were rapidly spreading over a period of 1 to 1.5 months despite continuation of chemotherapy. Bacillary angiomatosis, Kaposi sarcoma, and multiple myeloma with cutaneous manifestation was included in the differential diagnosis. On investigation, her complete blood count showed decrease in all cell lines and her renal functions were mildly deranged. On skin histopathology, epidermis showed hyperkeratosis, follicular plugging, and thinning, and there was diffuse interstitial and nodular infiltrate comprising neoplastic plasma cells in skin. On immunohistochemistry, CD4, CD5, and CD138 were positive in reactive T cells, and CD56, MUM1, and kappa were positive in neoplastic plasma cells. On the basis of history, clinical examination, and investigations, the final diagnosis, multiple myeloma with cutaneous plasma cell infiltration, was made. She was managed conservatively, and lesions improved in subsequent sessions of chemotherapy for multiple myeloma. However, her systemic disease continued to progress. These are the clinical images of patients after improvement in cutaneous lesions. The final outcome. Patient's condition deteriorated over next 4 months. She developed complications. She developed renal failure, refractory anemia, and went into multi-organ failure. And unfortunately, she passed away in May 2025 due to disease-related complications. Now, the topic discussion. The most common plasma cell malignancies are multiple myeloma and Waldenstrom macroglobulinemia. Apart from the bone marrow, neoplastic plasma cells may also develop in extramedullary locations. Cutaneous plasma cell infiltration in pre-existing multiple myeloma and Waldenstrom macroglobulinemia is a rare phenomenon, with approximately 100 cases described in the literature. The lesions are described as firm, smooth, violaceous nodules. In most cases, skin lesions appear relatively late in the course of multiple myeloma or Waldenstrom macroglobulinemia and indicate an unfavorable outcome. The case discussed in my presentation mirrors this rare clinical scenario, demonstrating late onset cutaneous involvement in an established plasma cell malignancy with poor patient outcome. Moving on to literature review. This article published in JED in May 2016 demonstrates that cutaneous involvement with multiple myeloma is associated with aggressive biologic behavior and short survival. Another case series published in JAMA Dermatology included 8 patients who were known cases of multiple myeloma and later presented with cutaneous metastasis. This study also supports my point that multiple myeloma showed a short survival once cutaneous metastasis appeared independently of the therapy. In this study, all 8 patients died a few months after the development of cutaneous involvement, despite aggressive chemotherapy. These are the clinical images of 2 of the cases. Case 1 showing multiple violaceous nodules on the lower back of patient and numerous erythematous nodules on the right anterior portion of the chest of patient are shown in case 2. Key takeaways. Cutaneous lesions can represent aggressive disease progression in multiple myeloma. Improvement in skin lesion post-chemotherapy does not rule out systemic progression. Prognosis may remain poor despite localized response. These are some of the references which I have used. Thank you everyone for patience listening. Now, I would like to invite my supervisor, Dr. Madhiya Hanif, for comment.
First of all, I would like to congratulate our last presenter for her diligent work on this case. As in this case, a patient is a known case of multiple myeloma and on chemotherapeutic drugs, and she was already in a state of immunocompromised. So first, initially we thought of some infectious etiology such like bacillary angiomatosis, but as patient is already on chemotherapeutic drugs and there was no any improvement in the lesions, so we after thorough and extensive workup, after skin biopsy, and we went for immunohistochemistry to final diagnosis. We land up with the final diagnosis of rare cutaneous manifestations of multiple myeloma. So but unfortunately patient was died because of the primary pathology that was multiple myeloma. So I must congratulate all of the presenters on this CPC. In the last, I would like to invite Dr. Mudassir for his closing remarks on this CPC.
We hope this session proved to be a valuable learning experience. and contributed meaningfully to our clinical understanding of dermatology. The discussion reinforced the importance of thoughtful assessment, sound clinical judgment, and collaborative learning in patient care. Before we conclude, we sincerely appreciate our senior dermatologists and head of the departments all over the country. Their experience and perspective are always invaluable, and we are grateful for their time. Thank you to our residents for your engagement and participation. We truly appreciate the shared learning and look forward to further such sessions in the future. And our special thanks to the Department of Histopathology who are always forthcoming to work with us.